For those of you who don't know Dr. Wright, I can tell you that he did his undergraduate studies at the Faculty of Kinesiology at the University of Calgary in Canada, after which he pursued his graduate studies in exercise physiology, initially at the Arizona State University and then later at the Bale State University, where he received his doctorate in human bioenergetics. Subsequently, Dr. Wright took on a postdoctoral fellowship in the lab of the great exercise physiologist John Holosy at the Washington University School of Medicine. Here, Dr. Wright focused on the potential of exercise to enhance glucose uptake and mitochondrial content in skeletal muscle. Since then, Dr. Wright has been heavily involved in illuminating the effect of diet and exercise in other tissues, especially adipose tissue, and in turn how these alterations regulate skeletal muscle and whole body glucose homeostasis. Today, Dr. Wright holds a professorship at the University of Guelph in Canada, and within recent years, Dr. Wright has performed pioneering work in deciphering the mechanisms involved in antipsychotic-induced hyperglycemia, which I believe he is also going to touch a bit upon today. So with that, please, David, the floor is yours.
Thanks for the introduction, Rasmus. It's a pleasure to be in this webinar today. I only wish I could be there, but with COVID-19 and a worldwide pandemic happening, I guess the best that we can do. So brief overview of what I'm going to talk about today. I'm going to talk about recent work from my lab looking at the metabolic side effects of second-generation antipsychotic drugs. I'm going to talk about mechanisms mediating these effects. I'm going to talk about, I think, some fairly interesting recent data from my lab looking at biological sex differences between males and females in terms of SGA-induced hyperglycemia. We're going to talk a little pharmacological treatment approaches. And then lastly, we're going to talk about the use of exercise and exercise-activated signaling pathways to offset some of these metabolic side effects. And so just to give a little background information, second-generation antipsychotic drugs antagonize dopamine, serotonin, histamine, and muscarinic receptors, amongst others. And these drugs were typically used for the treatment of schizophrenia. Now these compounds are widely being used off-label, and they're being used for the treatment and the management of a range of conditions, including anxiety, depression, bipolar disorder. They're used as sleep aids in elderly individuals, and at least in Canada, between 2005 to about 2012, prescriptions of these drugs have doubled to more than 7 million annually. And so while these drugs are extremely effective in reducing psychoses, there's some marked metabolic side effects in individuals that are prescribed these drugs. And so if we look at the natural progression of the metabolic syndrome in the general population as we age, you can see that as we get older, there's an increase in weight gain. This is associated with the development of insulin resistance and the appearance of fasting hyperglycemia. Now, you compare the progression of these endpoints in the general population to those that have been prescribed second-generation antipsychotic drugs, and you can see a very rapid development of weight gain. There's been case studies that have shown individuals gaining upwards of 20 kilograms within a year of the onset of SGA prescription. And perhaps not surprisingly, this is also associated with the development of fairly marked insulin resistance and fasting hyperglycemia as well. And the majority of studies, probably up until about 5-10 years ago, we're looking at the chronic long-term side effects of second-generation antipsychotic prescription. However, I think it's now well established that these drugs have direct effects on regulating glucose metabolism as well. And so this is work from a group in Japan. I could show you data from any other number of groups. But what they've done is they've taken male C57 black 6J mice and they've injected them IP with a second generation antipsychotic called olanzapine. And so this dose of drug corresponds to about 75% dopamine receptor occupancy. So this is a clinically relevant dose of olanzapine, at least going off of that criteria. And you can see that within about an hour, there's a marked development of hyperglycemia in these animals. I think it's important to note that this has also been recapitulated in humans as well. And so this was shown by colleagues of mine up at the University of Toronto. Maggie Hahn and Gary Remington have shown this in a patient population as well. So a direct effect of second generation antipsychotic drugs on the development of hyperglycemia, independent of any changes in body composition or weight gain. And so I was mentioning, while these drugs are extremely effective in reducing psychoses and subsequently are used in the treatment of schizophrenia, they also have these direct effects on perturbing glucose metabolism. And if you were to design a drug to cause hyperglycemia, I would probably argue that you would design second generation antipsychotic drug. And if we look at the peripheral mechanisms of how SGAs or second generation antipsychotics cause or drive hyperglycemia, they increase liver glucose production, they impair pancreatic beta cell insulin secretion, and they cause very marked development of insulin resistance in skeletal muscle, in adipose tissue, and in liver. And so we became interested in this probably about 5, 6, 7 years ago, and we wanted to try to tease out potential mechanisms that were mediating the acute effects of SGAs in terms of causing hyperglycemia. And this is work that was done by an ex-PhD student in my lab, Laura Castellani. And so she asked a very simple question. She wanted to determine whether or not increases in glucagon signaling could be mediating the acute hyperglycemic effects of olanzapine. And so in this first experiment, what Laura did is she took male C57 black 6J mice, treated these animals with either olanzapine or vehicle, and saw the expected increase in blood glucose. So you can see a very marked increase in the rise in blood glucose following olanzapine treatment, and this is shown in the right-hand panel when we quantify the area under the curve. Despite this development of hyperglycemia, there wasn't a compensatory increase in serum insulin concentrations, and the development of hyperglycemia was mirrored by about a 2-fold increase in circulating glucagon levels. And so what Laura did next, and this was done in collaboration with Maureen Sharon's group in New York, is she wanted to determine if the absence of intact glucagon signaling mediated the effects of olanzapine on causing hyperglycemia. So she repeated these experiments, and this time she did them in either male wild-type mice, whole-body glucagon receptor knockout animals. And see in the wild-type mice, when we treat with olanzapine, there's a rapid and robust increase in blood glucose levels. And this is almost completely absent. It is completely absent in the glucagon receptor knockout animal. And this tracked or was paralleled by blunted increases in indices of hepatic glucose production. So we think that this is fairly convincing evidence anyways that glucagon plays a role in mediating the acute effects of olanzapine and perhaps other second generation antipsychotics on the development of hyperglycemia. I think an important caveat of this data was all of our work up until this point was done in male mice. And so a PhD student in my lab, Kyle Medek, addressed this question, and he wanted to compare the acute effects of olanzapine in male versus female mice. So again, we used C57 black 6J mice. These were age-matched male and female animals, consistent with what we've shown before. When you treat a male mouse with olanzapine and look at the acute changes in blood glucose, you can see the development of hyperglycemia, and this is shown in panel C, the quantified area under the curve data. Now you do the same experiment, but this time in female mice, and that increase in blood glucose that is present in males is completely abrogated in females. So females would appear to be completely protected against olanzapine-induced hyperglycemia. So what Kyle wanted to do next was see if the neuroendocrine response to an olanzapine challenge was different between males and females. When he went ahead and he looked at changes in circulating glucagon levels, this is shown in this bottom panel B. As we had shown before, in male mice, there was about a twofold increase in circulating glucagon levels, and this was completely absent in female animals that were treated with olanzapine. And we also saw the opposite effect in terms of circulating insulin. So again, consistent with their previous work, when we took a male animal treated with olanzapine, despite this large increase in blood glucose levels, we don't see a compensatory increase in circulating insulin. However, in females, there is an increase in insulin. So we think that there's sex-specific differences in response to an acute olanzapine challenge in terms of the glucagon to insulin ratio. So I think because we're seeing these marked effects or marked differences between males and females, an obvious question becomes, what's the mechanism that's mediating this? So we think that female sex hormones are probably involved. This is preliminary data, so this is early days for this particular experiment. But what Kyle did next is we took female C57 black J mice, and they underwent bilateral ovarectomy surgery. So we removed the ovaries, we let the animals recover for about 6 weeks. And then in another group of animals that were overectomized, we did an acute 2-day treatment with estrogen. And so what we wanted to do was have an estrogen add-back condition where we weren't seeing large differences in body weight between the OVX and the OVX-E2. And that's why we chose this relatively short-term estrogen add-back experiment. And as you can see that in the sham-operated animals, there's no effect of olanzapine in terms of increasing the glucose area under the curve. In the overrectomized animals, we see a marked development of hyperglycemia. So this would be comparable to what we see in male mice. And with the 2-day estrogen add-back, we're able to completely protect against. So again, I should say that this is unpublished data and kind of early days. But what we're starting to look at now is if this protective effect of estrogen add-back is mediated or paralleled by similar changes in the glucagon insulin ratio as well. And so I think I've hopefully convinced you that second generation antipsychotic drugs have fairly marked side effects, both chronically and acutely as well. And so I think it really begs the question, what are some pharmacological and or lifestyle approaches that we can take to offset some of these metabolic side effects? So this is work a colleague's lab out at the University of British Columbia in Vancouver, Alistair Barr, and he's done some of the first work looking at pharmacological approaches to offset the acute metabolic side effects of some of these second generation antipsychotics. And so he's done a series of studies using, and I'm only showing data with this metformin co-treatment and rosiglitazone co-treatment approaches. He's also done similar studies using glyburide. But what they did is they treated animals with either a low dose or a high dose of olanzapine, and then either with a low dose or a high dose of either metformin or rosiglitazone, and then measured differences in glucose homeostasis. And I think you can clearly see that both metformin and rosiglitazone are partially effective in terms of protecting against these acute metabolic perturbations in glucose homeostasis, but not completely effective by any stretch of the imagination. So based on our prior work, in which we saw modulation of the glucagon to insulin ratio with the acute olanzapine treatment, we thought that perhaps using drugs that are known to target glucagon secretion and insulin secretion could be an effective co-treatment approach to offset hyperglycemia induced by olanzapine. And this is a recently published study in HAP Endo that Kyle Medak, who's a PhD student in my lab, led. And so he asked a pretty simple question. He wanted to see if a GLP-1 receptor agonist, liraglutide, when co-treated with olanzapine, could offset olanzapine-induced metabolic dysfunction or hyperglycemia. And so what he did was He co-treated, so injected animals at the same time with either liraglutide, which is a GLP-1 receptor agonist, or olanzapine. And you can see that in the vehicle-treated animals, again, there's the development of hyperglycemia. I should say that these are in male C57 mice. And when you co-treat at the same time with liraglutide, we're able to completely protect against olanzapine-induced hyperglycemia. And this is paralleled by a liraglutide-induced suppression of the increase in glucagon with olanzapine treatment and an increase in insulin secretion. So co-treating with a GLP-1 receptor agonist seems to be able to protect against acute olanzapine-induced hyperglycemia. And we've also shown this not only with liraglutide, but with Exendin 4 as well. And so what Kyle did next is he did the reverse experiment. In this experiment, he looked at male mice that develop olanzapine-induced hyperglycemia, and by using a GLP-1 receptor agonist, he was able to protect against this. In the next experiment, what he did, he took female mice that are protected against olanzapine-induced hyperglycemia, and this time co-treated with a GLP-1 receptor antagonist, so Exendin 939. And you can see here that, again, in the female mice that are treated with olanzapine, they're protected against olanzapine-induced hyperglycemia. You co-treat with Exendin 939, which is a GLP-1 receptor antagonist, and there's a potentiated olanzapine response. This is associated with a greater olanzapine-induced increase in circulating glucagon levels and a suppression of olanzapine-induced increases in insulin secretion. And so just summarizing some of what I've talked about in the first portion of my talk, I've shown you some evidence that SGAs cause sex-dependent increases in blood glucose, that SGAs induce hyperglycemia through a mechanism that likely includes increases in glucagon, and that pharmacological targeting of the GLP-1 receptor could be an effective approach to offset the acute metabolic side effects of SGAs. And I should say that work out of Copenhagen has shown that liraglutide is actually effective in protecting against the chronic metabolic side effects of second-generation antipsychotics as well. So I think our data is quite complementary to that, which has recently been published. And so this really kind of led us to our next question. My lab is an exercise lab, so what we're really interested in is exercise physiology, exercise biochemistry. So we kind of asked the really basic question, are there lifestyle interventions that could be used to confer the same protective effects of some of these pharmacological agents that I've talked about? And so we've done a series of studies attempting to look at this, and we've used two different models of exercise. We've used forced treadmill running, and we've used voluntary wheel running. So in our first experiment, what we did is we ran male C57 black 6J mice to exhaustion on a treadmill. Immediately after that bit of exercise, we treated them with olanzapine, and you can see that a prior bout of exhaustive exercise completely protects against olanzapine-induced hyperglycemia. So in the sedentary mouse, you can see that there's the development of hyperglycemia, as we've shown previously. In the animals that exercised immediately before treatment with olanzapine, the olanzapine-induced increase in blood glucose is completely absent. We've also done experiments where and this is work that's currently under re-review, we've done experiments where given mice access to a voluntary running wheel for one night prior to treatment in the morning with olanzapine. You can see, again, in the sedentary animal, we see an increase in blood glucose levels with olanzapine treatment, and voluntary wheel running, which is a voluntary form of physical exercise similar to forced treadmill running, is able to completely protect against olanzapine-induced hyperglycemia, which I think is a fairly interesting finding. So from an experimental standpoint, I think this exercise data is very interesting, right? So it provides proof of principle that exercise could be used as a therapeutic modality to protect against the acute metabolic side effects of some of these second-generation antipsychotic drugs. Now, one of the issues becomes is that individuals that are prescribed second-generation antipsychotic medications, exercise adherence is notoriously poor in these individuals. So they have amotivation, apathy, social withdrawal, that would make this type of exercise prescription difficult in individuals that are prescribed these drugs. So we've kind of taken a step back and reframed our thinking a little bit and kind of asked the question, we know that exercise works and is effective in protecting against these metabolic side effects of second-generation antipsychotics. So can we use this as a model to identify pathways that we could pharmacologically target to potentially protect against some of these metabolic side effects? And an obvious candidate would be the activation of AMPK. So 5' AMP activated protein kinase. I don't think I need to describe the importance of this enzyme to the participants in this webinar. And I think that there's some very interesting evidence that would perhaps link reductions in AMPK activity to susceptibility to SGA-induced weight gain. So this is work that came out of the Center for Addiction and Mental Health up the road at the University of Toronto. And they showed an association between single nucleotide polymorphisms in AMPK and antipsychotic-induced weight gain. So I think this provides some proof of principle that maybe our working hypothesis could be correct. However, others have suggested, and this is work from a group in Japan, that the activation of AMPK centrally in the hypothalamus could actually be mediating olanzapine-induced disturbances in glucose metabolism. I would say that a caveat from this group is that the administration of the drug has been done centrally. So olanzapine delivery through a cannula directly into the hypothalamus, which obviously would not be how patients would be dosed with this drug. So as a kind of a first attempt to answer this question, whether or not AMPK agonists could be equally effective as exercise in protecting against olanzapine-induced disturbances in glucose metabolism, we use a drug called ACAR. ACAR is a non-specific AMPK activator. It gets taken up by skeletal muscle and other tissues, converted to ZMP. And that conversion of ACAR to ZMP activates AMPK. And so here, just as kind of proof of principle, ACAR treatment in our hands leads to a fairly nice activation of AMPK in vivo in both skeletal muscle and in liver. And when we take an animal and co-treat with ACAR and olanzapine at the same time, olanzapine-induced hyperglycemia is mitigated. Actually, it's completely protected. Now, I did mention that ACAR was non-specific, so it does have some off-target effects. Work from Dave Wasserman's group has shown that the glucose-lowering effects of ACAR are completely intact in liver-specific AMPK knockout animals. And so we wanted to test a more specific AMPK activator. And one of the ways that we did that was we utilized AMPK beta-1 knockout animals in combination with a specific AMPK beta-1 activator called A7. And so this was these were mice that we got from Greg Steinberg and Bruce Kemp. And so beta-1 subunit acts as a scaffold, and when it's knocked out, you see the degradation of the AMPK alpha catalytic subunit. And in liver anyways, in AMPK beta-1 knockout animals, you can see that there's a marked reduction in the phosphorylation of AMPK. When we take female AMPK beta-1 knockout animals and treat them with olanzapine, you can see that there is a subtle potentiation of olanzapine-induced hyperglycemia. What was interesting, though, is when we repeated these treatment experiments, we treated male C57 black 6J mice with either olanzapine with and without A7. You can see in the absence of A7, again, we see this development of hypoglycemia. When we co-treat with A7, which is a specific AMPK beta-1 activator, the development of olanzapine-induced hyperglycemia is completely mitigated. And I think importantly, when we repeated these experiments in AMPK beta-1 knockout mice, the protective effects of A7 were absent, suggesting that A7 is dependent upon the beta-1 subunit in vivo. And so just some conclusions and future directions. Exercise and drugs targeting AMPK beta-1 prevent acute SGA-induced increases in blood glucose. And so a question that we're really interested in answering, and this is actually our DDA-funded work, would targeting AMPK in skeletal muscle confer the same beneficial metabolic effects? And I think this is an important question because AMPK beta-1 is primarily expressed in the liver and in adipose tissue, not expressed to an appreciable extent in skeletal muscle. And then other questions in this line of research that we're currently addressing, would chronic treatment with AMPK agonists protect against SGA-induced weight gain and the development of fatty liver disease? And those are ongoing studies that we're currently completing right now. The most important slide for last, obviously the great folks in my lab that did this work, so Laura Castellani, Hashem Shamshum, Kyle Maddock, Natasha Bush, and Logan Townsend, collaborators that were involved in this work, and then our funders as well. And thank you for your attention, and I think I have time to answer a few questions. Here's my email address. If you get to your questions and you just want to fire me off an email, I'll be more than happy to answer any questions.
Great. Thank you, David, for this very exciting talk, I must say. The webinar is now open for questions, and the first question is from Jakob. He writes, "Thank you, David. Very interesting data. 2 questions. How much of the olanzapine effect on glucagon are direct effects on alpha cells? And the second is regarding your GLP-1 agonist data. What do you think is the mechanism there? Have you thought about somatostatin? The reason I'm asking is that it is debated whether GLP-1 affect alpha cells directly."
Right. Yeah. No. Thanks, Jacob. Great questions. We don't have expertise right now to measure direct effects of olanzapine on alpha cells. There is data out there, in vivo data, where they directly deliver olanzapine centrally, and there's a decreased, I'm trying to remember this data, decreased parasympathetic outflow and subsequent increases in glucagon secretion. So to your point about direct versus indirect, it's probably a little bit of column A and a little bit of column B. So I think there's probably 2 mechanisms mediating that. In terms of your second question, we've thought about it a little bit. I don't have a good answer for you, unfortunately.
All right, thank you. Thank you, David. The next question is from Nicola Watson. Is SGA-induced hypoglycemia dose-related?
Yeah, so it is. And so we've done experiments. We've started at 1 milligram per kilogram, and we've gone up to 5 mg per kg body weight. At least in our hands, we start to see the development of hyperglycemia at around 2 to 2.5 mg per kg body weight. So it is dose dependent for sure.
The next question is from Jens Helling. Thanks, David. You showed that SGA treatment increases body weight. What do you think is the mechanism? Increased food intake or reduced energy expenditure?
Yeah, great question. So we're in the midst of doing those experiments now. Our treatment with SGA long-term is different than how we do our acute experiments. So we incorporate it into the diet. It causes hyperphagia. And so it's the increases in weight gain are primarily driven by hyperphagia and a little bit of a reduction in total energy expenditure. That reduction in total energy expenditure is due to decreases in physical activity levels. So it has a bit of a sedating effect.
All right, thank you. David. And then Eric Richter would like to be unmuted.
Erik, you are unmuted.
Thank you. Thank you very much, David. Very nice talk, very nice data. I was just wondering, so the effect of exercise that you see on the acute effect of the SGA, is that an effect on the liver or on the muscles or on the fat for that matter?
Yes, yeah, great question, and thank you for that, Eric. I think it depends upon the mode of exercise that you're looking at. And so when we do our exhaustive exercise by force treadmill running, I think what we're primarily seeing in terms of a protective effect is the residual effects of contraction-stimulated glucose uptake and an increase in post-exercise insulin sensitivity. With voluntary wheel running, I think it's a different mechanism. And with voluntary wheel running, and this work is currently under review, we see an ability of prior voluntary wheel running to modulate the ability of olanzapine to increase glucagon. So that's suppressed.
So you see a difference between the two exercise modes?
Yeah, we do. Yeah.
Why is that?
Good question. I mean, if you look at the total amount or the total volume of exercise done, it's much greater with voluntary wheel running. So, probably somewhere in the neighborhood of 4 to 6 kilometers a night. And the mice could be in the wheels for upwards of 8 hours versus our exhaustive bout of exercise is, the mice are probably running for about 75 minutes total. So I just think it's an entirely different beast when you're comparing those two modes of exercise.
Oh, very interesting. Thank you.
You're welcome.
And then we have a question from Ansel. Thank you for a great presentation, David. You mentioned that female mice were somewhat protected from hypoglycemia. Some studies report that males gain less weight. Have you seen any differences in the body weight between both sexes? And would you say that this hypoglycemia is weight gain independent in this case?
Yes. So with our chronic feeding interventions, when we incorporate olanzapine into the high-fat diet, we don't see much of an effect at all in males. And in females, they gain probably 75% more than the control. So there's clear sex differences there. In terms of the acute effects, we've also done experiments where we've matched for body weight. And so the data that I showed, we had matched for age and not weight. So we've actually matched for weight. And when we do that, we still see that sexually dimorphic response. So females still protected compared to males.
Right. And then a question from Nicholas. Why does the insulin increase upon SGA injection in female mice? Why does that not lead to glucose lowering?
Yeah. So I didn't show the data, but if you look in female mice, even though they don't develop hyperglycemia, when we look at when we do an insulin tolerance test post olanzapine treatment, they're still very insulin resistant. So we think what's explaining the difference between males and females is females don't display olanzapine-induced increases in liver glucose production, at least as we measured it using a pyruvate tolerance test.
All right.
Yeah.
And then, no, sorry, Dave.
I was going to say, so in females, you still have the development of peripheral insulin resistance. Just for whatever reason, there isn't an olanzapine-induced increase in liver glucose production.
All right, and I'll just take the liberty to ask you a question myself. So I've read into your studies, and for me, I can't really see whether for the liver glucose or the glucose produced in the liver, where it comes from, because you see no differences in glycogen levels.
This is true. Yeah, we don't see any differences in glycogen levels. Yeah, and so in males anyways, what we see is there's a large increase in circulating non-esterified fatty acids and glycerol as well. So adipose tissue lipolysis is increased.
So what
And
you're
so
saying is that the glucose from the liver is generated by when it takes up glycerol from the circulation.
Yeah, that's our guess.
All right. So we have a question from Opal. Is there evidence that individuals experienced SGA-induced weight gain have their weight normalized after they stop taking the SGA?
I'm not familiar with any data that would suggest that. At least if you're talking about an individual with schizophrenia, and if it's severe schizophrenia or another kind of severe mental illness, once individuals are on these drugs, they pretty much have to stay on them. If individuals go off the drugs, then you see increases in attempted suicide, hospitalization, etc.
Then a question from Rubinder. Hi, thank you for an excellent talk, David. I had a query regarding my results. If you could explain, I have tried using olanzapine in both mice and rats, females, but I only observed hyperphagia starting within first week. No weight gain was observed until 28 days.
Yeah.
Is there any possible explanation?
How are you dosing with olanzapine? And so we found when we first started doing these chronic experiments, we tried doing daily injections, and we didn't see any increases in weight gain or hyperphagia when we do daily injections. We think it's probably stress related. And so at least in our hands, in order to see weight gain and hyperphagia, you have to incorporate it into the diet somehow. The other approach that folks have used is using mini osmotic pump. But again, there's some stress associated with that as well. Olanzapine will start to degrade after about 10 days in a mini osmotic pump. So you're going to have to switch it out several times, depending upon your length of treatment.
Right. And then a question from Nicola. Are female patients with PCOS adversely affected by the SGA-induced hyperglycemia?
Oh, are they? Not familiar with that area. Perhaps.
Oh. And then a question from Jørgen. Are there human data on effects of olanzapine pre and post menopause?
Pre and post. There has been a lot of studies, cross-sectional epidemiological type studies. And depending upon who you read, they would suggest that postmenopausal women, the metabolic side effects can be potentiated. So worsened, yep.
Yeah.
Yep.
And then a question from Maria. Do you think the insulin resistance is mediated through central effects, peripheral, or both?
Probably both. Yeah, probably both for sure. There's large increases in circulating fatty acids, and so you know with an in vivo injection of olanzapine or clozapine, we see probably a doubling in circulating non-esterified fatty acid levels. So that could be a player for sure.
All right. And then another one from Jørgen. Have you measured AMPK isoform specific activity with olanzapine?
Nope, not as of yet. That's why I want to come to his lab.
Anyone else? So I have a question, David. So the GLP-1 agonist, liraglutide, how does that work? Like a mechanism, is it muscle? Some evidence suggests that it works on muscle, at least in muscle cells to increase glucose uptake.
Yeah, so we think that what we're seeing is probably mediated at the level of the pancreas, because we're seeing really robust alteration in the ability of insulin to increase the glucagon to insulin ratio. And when we co-treat with liraglutide, that's completely negated. So we think, at least in our hands, that what we're probably looking at is a pancreas specific effect.
And then another question from Opal. Will there be an interest to explore whether there is long-term damage to liver or pancreas due to the SGA-induced hypoglycemia or insulin resistance if patients are on SGA for life?
Yes, absolutely. Yep. And so we've done feeding studies in mice, so female mice, and we after about 6 weeks of treatment, when we compare the high-fat diet group to the high-fat diet plus olanzapine, and we look at liver triglycerides, it's probably twofold higher in the SGA-treated mouse than in the high-fat mouse alone. So fatty liver disease is exacerbated for sure with long-term treatment.
All right, and then another question from Asel. You have mentioned increased lipolysis in mice after olanzapine administration. Incubation adipose tissue ex vivo with the drug does not show any effect on lipolysis after 3 days incubation.
Yep.
Would you recon this could be due to effect on the drug on the adipose tissue, sympathetic innervation?
Yes, 100%. Yeah, and we're doing those studies right now. So we don't think that the lipolysis effect that we're seeing in vivo, it's direct. We think it's secondary.
And what
Great.
about the muscle? Is that direct? Muscle
we haven't done those experiments. I've talked to a colleague of mine here at Guelph, Dave Dick, and we want to do those experiments. So just isolated muscle strips and treat or not with olanzapine and measure insulin signaling or 2-deoxyglucose uptake. Yeah.
All right.
Yeah.
Right.
That was a lot of questions. Thank you. I want to ask you to I have 2 questions there, Paul. I hope you will take your time to answer it. And while you're doing that, we might have a last question in the chat. If any of you still have a question, please write it in the chat now, or just write your name, then we will unmute you. Great, thanks for filling out the poll. We really appreciate that.
And thank you, David, for a very nice talk and a great discussion.
Thank you. Hope to see everyone soon in person.
Yeah. We hope you will be able to travel to Denmark soon as well. So sometimes it takes some time before a question appears in the chat, but it seems that there is no more questions. At least I cannot see any. Oh, there was one. Rasmus, I do not think you can see it. It's from Opal again. I will just copy it to all panelists. Oh, yes. It is from Opal.
All right. From Opal, for mice that did not have weight gain after SGA treatment, what is different about them than the one which did?
After SGA for mice. So in female mice, we consistently see SGA-induced weight gain. Male mice, we don't. And it would also appear to depend to a large extent on, at least in our hands, housing temperature as well. So if we house female mice at room temperature, feed them an olanzapine supplemented diet, they don't gain weight. But when we do the same experiment but do it at thermoneutrality, they do.
Interesting.
Yeah.
Mm-hmm. All right, if that is no more questions, then I think we should.
I just have one more.
One more.
If we have time for one more, I know we already used the time.
Yeah, I got time.
Let's do a last question.
Yes, let's say that this is the last one. Here.
There it is. It's from Rugana and asking what makes female mice more prone to SGA-induced weight gain?
Right. And so we're not sure of the specific underlying mechanism. Male mice don't become hyperphagic, whereas female mice do. And so that SGA-induced weight gain, we think is secondary to increase in food intake, and then a slight reduction in total energy expenditure as well, secondary to decreases in physical activity levels.
Great. Thank you, David.
Yes, thank you, David, for your presentation and for answering all these questions. Thank you, Rasmus, for accepting to be chair of this webinar. And thank you to all of you who attended the webinar, and thank you for all your questions. We never had so many questions at a webinar before, so we really appreciate that. Thank you and bye-bye.
Great. Thanks, everyone. Take care.